Your surgeon told you to stay on crutches, but is that actually what you should do? Every week in practice, I see patients who are weeks or months behind where they should be. The pattern is always the same free mistakes repeated over and over in patients who did everything they were told to do. That's not a coincidence. These mistakes didn't happen randomly. There is a reason they keep showing up, and it has almost nothing to do with the patient. In this video, I'm going to walk you through all three mistakes. I'll tell you exactly what each one is, why it keeps happening, what it costs you in recovery time, and what the alternatives look like. By the end of this, you'll know exactly what questions to ask before your surgery, what to push back on after it, and how to tell whether your surgeon has the tools and the approaches to actually get you back on your feet as fast as possible. The old model of post-surgical care is built around one idea: protect the site, immobilize the joint, keep all weight off it, and let the body heal on its own timeline. For decades, that meant cast and crutches for weeks at a time, sometimes months. Patients were told this was the safe way, the careful way, the way that gave the repair the best chance of holding. That approach makes sense when it was developed. The surgical techniques of that era required it. The hardware being used required it. The understanding of tissue handling at that time supported it. And so it became standard. And it stayed the standard, even when every one of those underlying conditions changed. Here's what that model does to your body. Every day you're in a cast, not loading the joint, not moving through range of motion. Your muscles are atrophying. Atrophy begins faster than most people expect. It compounds. 2 weeks of immobilization can create a level of muscle loss that takes months to rebuild. 4 weeks doubles that problem. 6 weeks means that when the cast finally comes off, you're not starting your recovery from when the surgery left you. You're starting from significantly further back, because the immobilization itself has become its own injury on top of the original one. The cast was supposed to protect your recovery. In many cases, it's the single biggest obstacle to it. I want to be precise here, because this isn't about ignoring surgical protection. There are procedures and situations where a degree of immobilization is genuinely necessary. The problem isn't protection. The problem is a blanket approach to maximum immobilization in every patient, regardless of the procedure, the hardware, the individual, or whether modern techniques have made that level of restriction unnecessary. Active recovery and early weight bearing and early range of motion is the modern standard of care for the majority of ankle surgeries. That means getting the joint moving, get loads through the tissue in a controlled and progressive way, and preventing the atrophy that extended rest creates. When the surgical approach allows for it, patients begin moving the joint within days of the procedure, not weeks or months after the cast comes off. Most of our ankle reconstructive patients are walking within 10 days of surgery. In cases where we use circular ring external fixation, they're walking immediately after surgery. That's not a claim about pushing through pain or skipping steps. It's what happens when the surgical techniques, the hardware, and the post-operative plan are aligned around active recovery from the start. When you go into a pre-surgical consult, the question to ask isn't, what's the recovery timeline? The question is, why will I be non-weight bearing? For how long? And what specific reason my procedure requires that level of immobilization? If the answer is vague, or if the answer is, that's just how we do it, that's an important information about whether you're in the right place. The answer matters even more when you understand the second mistake, which is about what happens when your surgeon only has one way to do the reconstruction in the first place. Most patients assume that surgery is surgery, that the procedure itself is relatively standardized, that the tools are the tools, and what varies between surgeon is mostly experience level and bedside manner. The outcome they assume will be roughly the same. This is one of the most costly assumptions a patient can make. Surgical training is deep and specialized, but it's not always broad. A surgeon can spend years mastering one or two approaches to a given condition and become genuinely skilled with those approaches. The limitation isn't their competence. The limitation is when a patient comes in with a surgery that falls outside of those two approaches, the surgeon still has to do something, and what they reach for is what they know, even if it's not the best fit. When a surgeon has a limited toolkit, the patient gets shaped to fit the toolkit. A complex reconstruction that would have been best handled with ring external fixation and immediate ambulation gets handled with a more traditional approach, because that's what the surgeon has available. The patient gets the cast, the crutches, not because it's the best option, but because it's the only option the surgeon can offer. There are patients who've been living with foot and ankle deformities for years. and a significant number of them choose to live with the deformity rather than face surgery because the only recovery they've been offered requires months of immobilization. Some of them have gone further down the road than that. I've seen patients who've pursued amputation because they were told reconstructive surgery would be too large, too long, too debilitating to recover from. When the surgical approach was actually right for the condition, that wasn't true. But by then, the decision's already been made. I want to be clear that this isn't about one technique being universally superior. Circular ring external fixation isn't right for every patient or every procedure. The point isn't that one method wins. The point is that a surgeon who has 5 or 10 approaches to a given condition and one who selects the one that matches the patient in front of them is going to produce fundamentally different outcomes than a surgeon who applies the same 2 approaches to every patient regardless of fit. Ring external fixation with immediate ambulation allows patients to begin walking even after complex reconstruction. It decreases the muscle atrophy that otherwise is unavoidable after major surgery. For patients whose anatomy, condition, or lifestyle makes extended non-weight bearing genuinely harmful, it changes the category of outcome that's possible. We use minimal invasive surgical techniques where appropriate, small incisions, sometimes no stitches, advanced instrumentation that reduces tissue disruption. The result is a recovery that starts from a less compromised baseline. Combined with active recovery protocols and regenerative medicine approach, the trajectory is different from the start. Before surgery, ask your surgeon directly, how many approaches do you use for this reconstruction? What determines which one you choose for me? Is immediate or early weight bearing possible with the technique you're recommending? And if not, what specifically prevents it in my case? A surgeon with a deep toolkit will be able to answer these questions specifically. A surgeon without one won't. Both of those mistakes, the passive recovery and the limited toolkit, are serious. But the third one can make both of them irrelevant because it happens before surgery even begins. If this lands for you, hit subscribe before we go further. I put out videos specifically for people who want to understand what's actually happening in their treatment, not just what they've been told to accept. Subscribing is the fastest way to make sure that you see them. Consider a patient who already had an ankle reconstruction. The procedure was done, the recovery was complete, and within a relatively short period of time, the problem came back. The deformity returned, the pain returned, the dysfunction returned. They came in with the question everyone in that situation has. Why didn't it work? In cases like that, what becomes clear very quickly is that the original procedure addressed what the surgeon could see. It addressed the structural presentation, the visible deformity, the shape of the problem. What it didn't address was the underlying cause, the reason the deformity existed in the first place. The root was left untouched, and so the problem grew back. We had a patient, Alice, who came into us after a failed reconstructive surgery elsewhere for Charcot foot. The prior surgery hadn't held. When we did a full MRI and a CT workup, staged the approach appropriately, and addressed the actual underlying cause, including metallic spacing implants where the bone had been compromised, she returned to regular shoes. The outcome of the second surgery wasn't different because the technique was dramatically different, but because we knew what we were actually treating. Before any ankle surgery, there are diagnostic questions that have to be answered. What's causing the structural problem? Not just what does the structural problem look like. Is there a metabolic, vascular, or neurological component that has driven the deformity? Has the soft tissue, bone quality, and joint integrity been fully addressed using current imaging techniques? Is the proposed procedure targeting the cause or just the presentation? A surgeon who moves from examination to surgical plan without full imaging, without ruling out contributing causes, and without a diagnosis that holds up to scrutiny is setting up for a recovery that solves the wrong problem. The surgery may go perfect. The procedure may be executed exactly as planned, and the patient may find themselves back in the office 6 months later because the underlying issue was never found. When all 3 of these mistakes are avoided, when the recovery is active, the surgical approach is matched to the patient, and the diagnosis is complete before the first incision, what actually changes in a recovery isn't incremental, it's categorical. The difference between a recovery built on a full diagnosis, a matched surgical approach, and an active postoperative protocol versus one built on the old default isn't a matter of a few extra weeks. The old model produces recovery that stretches into months. The patient's rebuilding atrophied muscles, managing complications from immobilization, and sometime returning for additional procedures because the root cause was never addressed. The new model produces recoveries where the patients are functioning within days to weeks, and where the need for additional procedures drops dramatically because the underlying problem was solved the first time. Same patient population, same conditions, same severity. What changed the outcome is the decision framework around those 3 points. Full diagnostic workup, surgical approach selected to match the patient, active recovery from day one. When all 3 are present, the recovery clock runs at a fundamentally different speed. Stop accepting the timeline you were given as if it's fixed. Stop assuming that every surgeon has the same approach option. Stop letting the pre-surgical consult in without asking what the imaging showed about the underlying condition. Start treating the pre-surgical consult as a diagnostic interview. You're evaluating whether this surgeon has what your case requires. Ask about diagnostic workups. Ask about approach options. Ask specifically about what makes your recovery active rather than passive. A surgeon who welcomes those questions is giving you information. A surgeon who doesn't is also giving you information. That brings everything in this video down to one practical action, not a list of things to remember. One thing you can do tonight that will tell you whether your current situation has these 3 mistakes in it. You don't need to audit your entire surgical history tonight. You don't need to find a new surgeon or cancel anything. You need to ask one question and see whether you can answer it. The question is, do I know what caused the problem that surgery is meant to fix? Or am I only being treated for what it looks like? If your basement floods, you can pull up the carpet, you can dry out the subfloor, you can repaint the walls. That's a real intervention. The problem will look solved. But if the pipe that causes the flooding is still leaking, the carpet will get wet again in 6 months. Ankle surgery without a complete diagnostic workup is the same dynamic. The structural intervention is real. The recovery is real. The problem is real. And without the root cause being addressed, the return is also real. Most patients who are in the 2nd or 3rd ankle procedure didn't fail their first one. Their first procedure failed them because the full diagnostic picture was never established. That's not a criticism of those patients. They didn't know what to ask. Now you do. Tonight, go back through what you've been told about your diagnosis. Ask yourself, has anyone ordered an MRI, a CT? Has the underlying metabolic or structural causes been named specifically, not just described visually? Has your surgeon told you which approach they'll be using and why they chose it for your case? If you can't answer these questions, that's your starting point. Write them down. Bring them to your next appointment. Your recovery timeline may depend on what happens in that conversation. These 3 mistakes aren't rare. They're the norm. They persist because the standard of care in ankle surgery hasn't kept pace with what's actually possible. And most patients don't know enough to ask what's available. But you do. Use it. If you want to understand more about active early recovery looks like in this practice, what happens in the first 10 days after the right ankle procedure, what walking after reconstructive surgery actually means, and how this practice built around same-day mobility operates, the next video covers exactly that. It's specifically about what happens when you walk out of the surgical suite the same day, and why that's possible far more often than most patients have been told. That video is linked right here. I'll see you there.